schizophrenia today. Schizophrenia is a major psychotic disorder. It affects higher brain functions, such as thought, language, emotion. It is one of the most common causes of psychosis. It is a devastating and debilitating disease. Typically occurs in 3 phases. An acute phase, in which people experience severe psychotic symptoms, sometimes with a somewhat sudden onset.
Mrs. Hay,
Yes.
You haven't started your slideshow yet?
Well, most of this isn't on there, but
Okay. We were just making sure that we were not behind, so I don't.
I know you're fine. You're good. I don't. That was a good call. Hold on, I'm starting lecture capture because somebody here reminded me I should do that. Okay, so we'll go back 3 phases. First phase is acute. It's a phase of severe psychotic symptoms, somewhat sudden onset. The next phase is stabilizing, so the client's getting better. The most improved phase we have is that they're stabilized. So they're still going to experience symptoms, hallucinations, and delusions, but hopefully we have reduced intensity and those are less debilitating at that point. Most people are going to go through these phases repeatedly with periods of stability and then returning periods of intense psychosis again. Treatment can provide temporary relief and improvement, but it does not resolve completely. Most people never return to their pre-psychosis function. So we can improve them some. They're always going to have schizophrenia. They're always going to struggle. They're always going to need to be medicated. Particularly hard disorder on families because the personality itself deteriorates, so they become maybe a person that they no longer recognize or know. Okay, so most common symptoms, we'll talk about others, but the most commonly thought of symptoms with it are hallucinations, delusions, and difficulty organizing thoughts. Schizophrenia causes disturbances in perception. So people may misperceive, what? Yeah. Difficulty organizing thoughts. And while you guys are writing, since we started kind of weirdly there, on that patient review, at least when I looked this morning, I probably already had 16 of you guys had completed it. You don't necessarily have to send it to me. It will show up on the gradebook on Evolve. Under one condition, you have to give it time to load when you finish. So when you finish, give it a little bit to get your grade loaded to the gradebook. Don't just exit immediately. So other than that, you shouldn't need to necessarily send it to me. You can if you want to. I'm not opposed to that, but you don't have to. Remember, that's due Thursday at noon. Yes?
The students were asking, what was the 3rd phase? The acute phase?
Oh, it's kind of confusing because it's stabilizing and then stabilized, like a past tense, stabilized.
Did you just start over that one? You asked for the phases again.
They're on page 249.
Acute,
It's a
stabilizing, and
perceptual,
stabilized.
and if you want, I've got some page numbers. This is on page 248, some of this information. If that's help, if you want to highlight instead of trying to write, that may help too. But perception disturbances. This can be visual, can be auditory, can be tactile. So they may see things, hear things, feel things that aren't really there. It can even include tastes and smells. So any of your senses can be involved in those sensory perception alterations. They're going to have disturbances in thought, have difficulty following kind of a logical progress. Their thoughts are going to be disjointed, disorganized, kind of scattered. Have disturbances in reality. So they may have delusions that are going to seem very obviously false to you. Things like that they're in great power and great danger, but they're very real to them. All of their sensory stimuli is telling them that that is a real experience for them. They have disturbances in feeling, so their reactions to situations may seem inappropriate to you. Their affect, which we'll talk about later. What's affect, Stillwater? Have you talked about that in lab at all?
How they put, I guess, project, or how their facial expressions or their body movements or anything like that, whether it's appropriate for what's going on. Like if
That's a very good definition of it. It's that kind of how they show emotion, basically with their face or their body. And we'll talk more about different disturbances in that throughout the semester, but affect is a certainly important concept when we look at mental health nursing, something to keep in mind. So these people have disturbances in their feelings and also the affect, the way they show those feelings. Behavior, they're gonna have disturbances. They're not gonna follow social norms for behavior. Often these are the things you may notice as a layperson from a distance. Maybe if you've been driving somewhere and you've noticed someone who looked homeless walking along the street, maybe looking like they were talking to someone who wasn't there, or making movements that didn't really make sense to you. As we talked about before, mental health contributes a lot to homelessness. And so those may be signs that you physically, if you think back on, kind of seen before. They have disturbances in attention. So they have all those kind of random thought processes flying around. And so they can't focus or concentrate very well on a single thought process and follow it through. We'll talk about that more, but it kind of interferes with their ability to think through complex processes, basically, because they can't continue following that process through. They have trouble with motivation. So they're gonna have trouble with goal-directed activities. So like holding things together at work, or maybe even getting to the doctor to get their medicine, those things like that, where it takes a few steps to reach that goal. They're sometimes not even gonna have to be motivated to do that, even if they are, capable of following through the process. Schizophrenia typically appears in adolescence or in early adulthood. So that's the patient population where you're going to be watching most. We'll talk later at the very end about health promotion, but a lot of times there are a few symptoms that we start to see maybe, that we'll talk about at the end, that can kind of give us a clue. The earlier people are treated with symptoms, people with symptoms are treated, the better their prognosis. Once again, it's not going to totally go away, but they're going to be more functional if we catch it earlier and get them on treatment earlier. So that's kind of the age group you'd be watching for those behaviors in. Affects about 1% of the population. More prominent in inner cities, lower socioeconomic classes, and in people who may have had prenatal difficulties. Keep in mind that a link between a condition and risk factors does not prove causality. So we're a lot of times in mental health issues talking about a certain level of heredity, of genetic heredity, along with environmental influences. So it may be that generations of suffering from a psychological illness are the reason that people are in a poor socioeconomic status, because throughout generations they've had trouble holding down a job and having trouble with family relationships and things like that. So it's not necessarily true that, a lower socioeconomic status contributes to the disorder. It may also just be that, having a family history of the disorder contributes to that status. Typically occurs 4 to 6 years earlier in males and is more severe in males. Women tend to have more positive symptoms, and we'll talk a little bit, or you might have even seen in your patient review a little bit about positive or negative symptoms. Women also tend to be more compliant with medications, and therefore women tend to have a better prognosis because positive symptoms are better treated with medications. So since they have more positive symptoms and we can treat them better and they take their meds better, they just tend to have better prognosis overall. Okay, so let's see how switching around here does for us.
I would reach a crossroad where I would stop and consider my options. I could either walk down the small, empty path, where I would be easily able to run without anyone looking. On the other hand, my pursuer would be able to kill me.
I'm going to start at the beginning because I think it started partway through.
I developed my psychosis around 7th grade. I started isolating myself from my classmates and developed a mild paranoia. I didn't trust anyone. Not my family, friends, or strangers on the street. On my way home from school, I would be convinced someone was following me. I would reach a crossroad where I would stop and consider my options. I could either walk down the small, empty path, where I would be easily able to run without anyone looking. On the other hand, my pursuer would be able to kill me without getting any attention. I could also walk down the big, open path to make it harder for him to attack me. But there's always the possibility. Some days I'd come home from school, stop in front of my door, and wink. When I stepped through this door, I'll find my family murdered on the floor. The pain and despair that rushes over you when you find your family dead. Will overwhelm you. Before you even open the door. I went through most of my life without even knowing that it is normal to feel that way. I didn't know anything else. I never told anyone, and I never talked about it. I had a constant anxiety that everything would go wrong. But when my paranoia developed into a psychosis, even my sanity, which should have told me that nothing would go wrong, started saying, of course it's gonna go wrong. Your mom is dead, and now you will be killed too.
That sounds pretty short.
Needless to say, the NYPD has apologized for the incident and has promised to get down to the bottom of this gripping issue. In other news, meteorologists are reporting extreme weather conditions for the next few days, though there's no confirmation. What are you doing? You're wasting time. You need to find the code.
It's in the books. It's in the numbers. You're worthless.
Figure it out. Don't be stupid. Figure it out.
Be
You're
smart.
an idiot. You don't know anything. You're nothing. You have no friends. It's in the books. Code C-O-D-E. Don't trust them.
It's in the books.
It's too cold.
It's too cold.
No, it's too hot.
Help us.
It's in the books.
Shh. They're coming for you. We need you. It's the aliens. They're looking for you.
Jump.
Jump.
Let's find code.
Don't
Don't
eat.
eat. Don't sleep.
Trust them.
Numbers. Look in every single
Get out of here.
It's in the books.
Tell them everything.
Don't tell us. It's a secret.
I have to get out.
You have to get out of here, but they're out there. What if they don't trust you?
Don't trust them. No, don't leave.
They're out there.
Is everything okay?
Nobody likes you.
Everything okay?
Do one more, it's a little bit long. longer.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct. Something wrong.
Yeah, sorry.
You're about to experience a brief simulation of a psychotic episode in a patient with schizophrenia. Schizophrenia can provide powerful experiences, especially for those undiagnosed or not being treated effectively enough. The symptoms you will experience represent a compilation of a range of sensory occurrences, as reported by actual patients. These occurrences include sights, sounds, as well as wind and even scents. If you have any discomfort during the experience, please signal a facilitator.
He's waking up now.
Oh, the phone woke him up. Don't answer. They'll know who you are.
You're a waste of space.
Why are you so stupid?
Waste of our time.
Stupid. So stupid. Worthless. We hate you.
He's gonna pick up the phone.
They'll know if you lie. Something wrong. Better.
Poison.
He's hanging up. Don't eat. Out to get you.
Poison.
They know about you. Poison.
Armed gunmen entered the convenience store on 14th. The suspect was described as medium in stature with a slightly youthful demeanor. Anyone with information about this incident is urged to contact.
They know. They know about you.
And in other news, officials have closed the northbound.
Time for meds. Don't do that.
Repair crews are on the scene. Now here's the story out of Chicago from last night. Two men posing as maintenance workers nearly made it out of the quick bite convenience store with the store's ATM machine.
Make a list. Make a longer list. You are ungrateful.
You're a waste of space. A waste of our time. Get a coffee now.
Don't drink it. Stupid. So stupid.
That smells awful. Don't drink that coffee.
The clerk told the man he had called police repairing the phone and left the machine.
Why are you so worthless?
So Scott, tell us how this weekend's weather.
Weather. Something wrong.
You know what, Chuck? There's just no doubt of the weekend weather. You hear that word? Weather's going to get
Something wrong. Weather.
And what are you going to do about it, huh?
Something wrong. You have to stop it.
You're just going to sit around, your stupid mouth open and do nothing?
You have to stop it. It's the weather. It's here for
Now
us.
he has to answer the door.
It's here for us. Do something. Stay in. Stay away from the door.
Stop the weather. Protect us.
Pizza!
You didn't order anything. No, don't answer. You're stupid to open that door. He has to open the door now.
Here you go.
Don't do it.
He'll be in trouble. Poison.
This is for you.
This is for you. He's working with them. He's part of the plot. This is for you. Shut the door. Shut it. Don't eat it. Poison. You're stupid to open. I hate you. We hate
Here's
you.
some items for today's activity discount. And you need some activities, especially when you're lazy and you sleep too much. Stop staring. I know what you're thinking.
He knows. You can't stop
They're
it.
coming for you. You know that.
Part of the plot. Your mind.
It's because you're so ungrateful.
Don't eat it. Poison.
No, don't open
He
it.
has to open the box.
This is entirely your fault.
Don't eat it. Don't eat it. Poison. Poison.
Stay here, and it's all your fault.
Oh.
No.
They know it's you. You're in.
Don't open the door.
You hear that?
No, don't open it. Don't open it.
They're here, and it's all your fault.
You did it.
You should have used your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hey, you all right in here? I called you. Why didn't you answer? I was like screaming, "It's Lorraine! It's Lorraine!" into the phone at the top of my lungs. What were you watching? Do you even remember? Did the pizza oh, what happened here? Forget to take your medicine this morning. Wow. You know it's not good to miss a dose.
Okay, so I think the videos are interesting. Certainly, there's no specific experience of schizophrenia, but it gives you a lot of different pieces that your clients might be experiencing. I think it also kind of puts you in that situation to understand why clients have behaviors and make choices that we don't necessarily understand. I mean, do you feel that anxiety when you're watching that video? Can you imagine living with that 24/7, that level of anxiety and not being able to sort out what were real pieces and what were not real pieces and that constant pressure that your clients are living under? And, we'll talk later too, medication adherence is a problem because they're getting conflicting voices about whether or not that can be helpful or not. I thought when I was looking at YouTube videos, one of the things that really spoke to me is just the comments under them, how people would comment and say, this is exactly what I experienced, or mine's different. One person commented about the fact that he'd ended up in jail and he could see out the window of his jail cell his mother being killed. And it was very, very real to him. He knew she was dead. He watched the people kill her. Then she shows up the next day to visit him. And you can't make sense of any of these things. So, just think one of the things is always going to be, it's hard sometimes, talk about this in our notes, but to separate the person from the behaviors, basically, that you've got to practice unconditional acceptance for that person and always be cognizant of what they're experiencing. So help them touch reality, help them learn skills that are going to help control behaviors, but always be, try to maintain that sense of understanding about the things that they're experiencing, how very real they are to them. Okay, onward, let's see. So losses that come with schizophrenia. Having watched these videos, it's not gonna be shocking to see some of these things. Most schizophrenics never marry. You don't necessarily have to don't memorize these stats just to kind of give you an idea of the magnitude. They're gonna have poor social interactions, 20% end up homeless, 40% who are severely disabled will be incarcerated at some point in their lifetime. Less than 15% are able to hold employment. There are pervasive homelessness, stigma, and isolation for this client group. This is the DSM stuff. I stuck it in here so you guys can kind of see it. You don't need to memorize it. You're not going to be tested over it. You do see a good list there of significant symptoms, but just kind of informational. Subtypes of schizophrenia. You may see mention of two subtypes, positive or type 1 and negative or type 2. This reference kind of helps us describe the symptoms being experienced by the client. It can help us in planning medication regimens and predicting responses, but it's also an oversimplification. Most of your clients are going to experience symptoms from both groups. They just may be predominantly more positive or predominantly more negative. When thinking about these, it helps to think of positive symptoms as a plus sign. So these symptoms are more than. They're exaggerations of what we would expect in normal behavior. Negative symptoms are a subtraction. So these symptoms indicate less than what would be expected. They're kind of the lack of symptoms. So these clients may have decreased speech, decreased movement, diminished thought processes. That'll kind of help you in memorizing them. There is one to me that's confusing when you think about it that way, and we'll touch on in a minute, is insomnia. Insomnia is actually a positive symptom, even though I kind of think we think about it as less sleep, so that one's a little bit confusing. What you have to think about is the things that contribute to that insomnia. And a lot of times for people, they can't sleep because they can't stop the thoughts and the stimuli that are coming into their head. So it's the positive symptoms that are making them not sleep. That's, I think, why it's classified that way. Generally speaking, like we talked about, positive symptoms are more susceptible to treatment than negative. Therefore, clients with more positive symptoms are going to have better outcomes. Positive symptoms, this is because positive symptoms are most often related to dopamine levels, so we can treat those fairly effectively. Whereas the negative symptoms have a more combined etiology. They come from dopamine, but they also tend to come from structural differences that we can't treat. So, And in fact, some of our traditional older antipsychotics may actually worsen the negative symptoms while treating the positive ones, but our newer generation ones do a little bit better job of not worsening those. So your next slide looks at some positive signs and symptoms of schizophrenia. So you've got abnormal thoughts, agitation, which I think when you watch those videos you can understand that sense of agitation and needing to move, needing to do. You've got some bizarre behaviors that are going to seem unnatural to us. You've got delusions. Talk about what's a delusion. Does anybody know a definition or a... That's okay. It's basically described as a fixed false belief. So it's fixed in that it's not easily changed, so they may continue to believe it even in the face of evidence that should disprove it. And it's also false. It's not a delusion if it's true. So that's kind of the basic definition of those. There are a lot of different kinds. These are in your book on page 254. They're not on the test this way, but it's kind of interesting to look at them. You can have erotomanic delusions, which are related to love, kind of like what you might see when you see like stalkers for movie stars who believe that that person's in love with them, those kind of delusions. You've got somatic, which have to do with the body. Grandiose are kind of those big ones we hear about, like I'm the Queen of England or I'm the Pope or something along those lines, big ideas. They may be religious in nature. You sometimes hear like a story on the news maybe where a mom has murdered her kids to save them, like she got that delusion in her head that the way for her to ensure their salvation was to actually kill them while they were innocent or something like that. That could fall under that religious delusion situation. Nihilistic, that might mean the client believes that they're dead or believes that they're missing part of their body, so having something to do with their existence, basically. And then reference, or you saw some of these in the videos, where they feel like the newspaper or the TV, or that everyone's talking about them, things that don't really refer to them, feel like they refer to them. If people in the room are talking, they're gonna feel like those people are talking about them. And then paranoid, you think of these commonly too, that's kind of that, they're out to get you delusion. Clients are going to show excitement, feelings of persecution, grandiosity, so they may have inflated senses of wealth, power, importance, talents. You see on that video that person, like, it's up to them to kind of solve this code. Like they have that grandiose belief that, they have to be working on this code, that it's their responsibility to take care of it. Can tend towards religious things like I talked about. So how, Enid, is a hallucination different from a delusion? What's a hallucination?
You actually see something?
Hallucination is something that they actually think that they see, maybe?
Yeah, it involves the senses, basically, is the primary difference. So it's not just a belief, but it is like something that they see, they hear, they feel, they smell, they taste. It's a sensory perception situation. They can, I don't know if this comes in this part, but they can actually be of two kinds. Sometimes you have a hallucination where there's no visual stimuli or no sound to go with it. Sometimes there is actually something like, there is some sort of visual stimuli, but they're misperceiving it and making it something more than it is. So you can have both of those kinds. Auditory hallucinations, especially that hearing voices or sounds, are critically important for us to notice because they're heavily linked to self-harm or harm of others. Because voices sometimes will tell them to do things or convince them that they're worthless or things like that. So those especially you need to be watching for. Clients may experience hostility. They may experience illusions. This is the other piece, I guess, that's different from hallucination because they have sensory input, but they are misperceiving it. Insomnia, we kind of talked about that is a positive symptom. We have to kind of stop and think about that. And then they may also have suspiciousness. The next page is the negative symptoms, and there's kind of a lot of vocab in this one since we're just starting into psych. The first one on there is alogia. So alogia is the inability to speak, but it specifically comes from not having the thought process to support the speech. So it's actually a problem with thought process that affects speech, not just with speech. Energia is kind of what you would think of if you add your little prefix there. It's basically they don't have energy. So they're going to have trouble getting motivated to get up and do things. Asocial behavior, similar concept to the A in front of us. They're not gonna wanna socialize, or they're gonna socialize differently than what fits societal norms. They're gonna have attention deficit. They've got all those competing things going on in their head. So they're back and forth all over the place. They have avolition, which is the lack of motivation. So they don't have a desire to do anything. So not just do they not have the energy to do it, they just don't really have the motivation or desire to do it either. And here's where we get a little more into affect. So if I say that, so it talks about here blunted affect. So let's talk about different types of affect, since we're kind of going to get into these with other lectures anyway. Appropriate, just what you would expect, basically. Like they are exhibiting the emotions that you would expect them to exhibit for the situation. Inappropriate, they are not. They're exhibiting emotions that are different than what you would expect for the situation. Blunted, which is the word we see here for schizophrenia, is a major reduction in the expected intensity of the emotions. So they may react a little, but not the way we would expect them to. So similar to what is flat affect?
Similar to blunted?
Yeah, it's kind of a more exacerbated version of blunted. They basically have little to no reaction, no emotional reaction to situations. And then talk about what is labile affect. You guys heard of that before? Okay, so labile affect is all over the place. It's an overreaction to things. So they may be happy, they may be sad, their emotions are kind of all over the place. They're exaggerated and rapidly changing. These clients are going to have communication difficulties. They're going to have difficulties with abstractions. And what that means is basically like they can't jump beyond concrete thoughts. So and one of these things you touch on in your mental status exams, you give them kind of a saying, like people who live in glass houses shouldn't throw stones, or the early bird catches the worm. They're unable to think about that in a theoretical way. Like, what does that really mean? I mean, they're going to be very concrete. Like, well, of course they shouldn't, because they would break their glass house. But that's not really what that saying means, right? So, that's another sign of this disorder, is they can't interpret those and apply them abstractly to life. They may have passive social withdrawal. You saw that in the video. The client talked about avoiding others, not feeling they could trust anyone. Poor grooming and hygiene. Remember, they're not motivated. They don't have any energy. They're busy dealing with all these competing stimuli. The fact that the social norms aren't really going to feel important to them. To have poor rapport, same thing. Rapport is kind of that connection that you make with people. Well, if they're dealing with all of these stimuli, they're not going to be able to go out and make small talk about, like what you're having for supper tonight, right? Like you would normally in a social situation. So they're going to kind of lose that connection with other people who aren't experiencing the same things that they are. Poverty of speech just means they're not going to speak a lot. This is partially the social situations. This is partially that they don't have the thought processes behind it. It's the competing stimuli, all of those things contributing to that situation. Your book kind of further divides, this won't be on the test either, the negative symptoms into primary and secondary, with the indication that our old way of thinking is that we couldn't really treat negative symptoms. But if you look at them in two groups, the primary symptoms are these negative symptoms that directly result from the disorder. Secondary ones are kind of the ones that build from the symptoms of the disorder. So losing their jobs, difficulties with their family, things like that. Those secondary ones are kind of treatable if we're dealing with them early. Like we can help them with job skills and things like that. And so that kind of subdivides those into those two groups. Then you can also look at them as objective or subjective. That's what your next couple of slides talk about here. I think we're going to talk about subjective first. And we'll go back to that one. So subjective, obviously, the ones that clients feel themselves. They can sometimes lead a client to seek treatment voluntarily. A lot of times, like that thought process aspect of them, they will feel mentally clouded and realize they can't think through things at work. And that may lead them to seek treatment early for that. You see the element of fear that you see in those videos. That's going to be a subjective one. Other subjective ones, the alterations in perception. Hold on, that is not. There. Altered perception, so hallucinations, illusions, paranoid thinking. You also have the alterations in thought. There's some other words there we haven't talked about before. So you've got loose association, Basically what that means is they've got those barely connected thought processes. They're kind of all over the place. They may think one word and that sends them off kind of on a rabbit trail over here and back and forth so that they can't get through a complex thought process. Retardation of thought basically means slow thought. So they're going to have a hard time processing through things. Blocking, it shows up as a speech issue, but it's really a thought process issue. Basically, it means like mid-sentence, they may just stop talking and just go silent. And that's because their thought process has been blocked there and they can't complete that thought. Autism is another issue. There's some studies that show an unexpectedly high frequency of comorbidity between schizophrenia and autism diagnosis. Once again, it's hard to establish causality, but it does appear that the two are linked. These clients may become so introspective that they become completely unaware of the external environment around them. This is obviously going to further impair their social interactions and communication. They also show that kind of autistic idea of repetitiveness in their behavior, so they may do the same thing, show interest in the same thing over and over and over, a fixated interest or fixated action, do the same thing repetitively, say the same thing repetitively. Ambivalence. Does anybody, Enid, do you guys know what ambivalence is?
Nope.
Two opposite strong feelings. Two opposite strong feelings.
Yeah, that's a good way to define it. The example like that might help you remember it is like sometimes when people find out they're pregnant or their partner's pregnant, they're really, really excited, but they're also really, really scared, right? And so those two emotions kind of coexist at the same time. And it's kind of that feeling, except with schizophrenia, you get exaggerated feelings of positive and negative, and it may be directed towards people or objects, and it can kind of paralyze the decision-making about something as silly as like what kind of Jell-O they want, because they feel so strongly both directions about it. So sometimes as nurses, we have to help out, not necessarily push them to make a decision, but maybe sometimes we may have to help them. We give them that sense of control when we can, but sometimes we're going to have to make decisions for them because they're just that ambivalence paralyzes them sometimes in decision-making. Delusions we've talked about, poverty of speech we talked about. Ideas of reference, we kind of talked about, we didn't talk about that exact phrasing of it. This is basically attaching extra meaning to events. So we kind of talked about like if they may see someone on the news talking about seeking a criminal and feel like they're talking about them. Or they may see two people across the room whispering and talking and they're sure that they're talking them or planning their death, or talking about them planning their death, things like that. So feeling like things that shouldn't, are just little things, but they feel meaningful to them and apply to them. And then mutism is the refusal or inability to speak. That next slide is still subjective. So take a look at it too while we're on subjective. So they have altered consciousness, some confusion, which makes sense given all the stimuli that's going on, the thought process issues, incoherent speech. Clouding, that phrase means a feeling of fog, kind of like, they can't quite perceive what's going on around them. They're having to fight through it. Nothing's very clear. And then they may actually just feel that feeling that they're going crazy, like they can subjectively feel that and they can't do anything about it. Alterations of affect, we talked about inappropriate, blunted, flat, labile. Apathy, basically that feeling of I don't care. I don't care what happens to me, I don't care what you do. We'll talk about that again too when we talk about depression because it comes commonly with that too. Ambivalence, overreactions to situations, and then another word that might not be familiar is anhedonia. Still a water, do you guys know what that word means? Anything? I didn't hear it if there was something.
No, they're a response.
Okay, so anhedonia, if you think about hedonism, has anybody ever heard of hedonism in Stillwater? Do you know what that is? No? Okay. So hedonism is the idea of like worshiping things that are pleasurable, like everything that's pleasurable, just doing whatever feels good. Anhedonia is the opposite of that. These people can't feel pleasure. Things that they previously enjoyed are not going to make them feel good. Nothing in life is going to feel like worth the effort, basically. All those things kind of compile together to make them sedentary and withdrawn. They don't have any energy, nothing feels important, nothing is pleasurable anyway, so why would I bother? And then that contributes to what you heard in the videos, those voices saying they're lazy and they're worthless and all these other things. So it kind of builds on each other. Okay, so back to objective ones then. So we're gonna see poor attention to appearance. So again, lack of energy, lack of motivation, apathy, in that diminished social skills. We see inadequate or inappropriate communication. You may see hostility, which isn't really surprising. They're feeling threatened all the time. You see that when like you get in that tense state that they're in and then somebody's at the door and you kind of feel that, horror movie feeling. So it's not surprising that they're gonna get violent sometimes. They're scared, they're frightened, they feel threatened by things. They're gonna withdraw. Psychomotor agitation, so you've got excessive psychomotor agitation. We kind of talked about that, that's one that we often observe in this. You can also have catatonic rigidity, which basically means that they may stay in one position for an extended period of time and just not move, be rigidly stuck in that position. You can't reposition them, they just stay frozen in that position. Echopraxia, think of that as an echo. They're gonna imitate the movements of another person. So if you make a gesture, they may mimic that gesture. Stereotypy is going to be them repeating the same thing over and over. So maybe the same motion, the same words over and over. And waxy flexibility is similar to the catatonic rigidity in that they stay in one position, but in this case, they're flexible to movement. So they may stay in an uncomfortable position, but you can go over and you can move them. Like you can move their arm, move their leg, and they'll stay in whatever position you put them in. Versus catatonic rigidity, where they're going to be rigid and it's going to be hard to move them out of a certain position. Some of these behaviors obviously are going to cross across. There are going to be subjective behaviors that influence objective behaviors and things like that. But this is just kind of a good way of being aware of all the things you might be looking for. What do these clients look like? And these are the kinds of things you're going to see. Nobody's going to have all of these, but different people are going to have different combinations of them. We already kind of looked at some special issues related to schizophrenia. We'll kind of hit these fairly quickly. You don't need to memorize these, but they have a really high incidence of hypertension, diabetes, cardiovascular disease, metabolic syndrome, accelerated aging, all those things that kind of relate to obesity. Most of them are going to be overweight at some point in their lifetime or obese. Some of this is due to like just being kind of frozen, the sedentary lifestyle. They may make poor diet choices. They're not going to be motivated to exercise necessarily. There's a lot of substance abuse in this population, of using substances to try to escape and deal with, to self-medicate those situations. And even medications that they take are going to contribute to obesity and make matters worse. We kind of talked about families. This is a really difficult situation for families to deal with. In addition to that, families kind of tend to get blamed sometimes for mental health disorders. So keeping that in mind as you're caring for people, that, the families probably already feel some level of guilt. Generally speaking, they don't need you to pile on to that. They're going to need a lot of support, basically, so that they can support their loved one. Depression and suicide, approximately 25% of those with schizophrenia also experience depression. As many as 20% of clients will attempt suicide, with up to 10% succeeding. Once again, I think when you watch the videos and you think about living in that situation with no sense of hope of getting out of it ever, it's really easy to understand why people would make that decision. Suicide is the leading cause of premature death for this population. That may be part of the reason they have a lower life expectancy. Cognitive dysfunction is significant, so it's important to discuss these issues with your client, be assessing for cognitive deficits. Cognitive deficits specifically are a good predictor for future progress in the disorder. The more severe their cognitive symptoms are, the less likely they're going to be to make it. They're going to have poorer outcomes if they have more cognitive decline. Also, these really affect functional living, make it hard to hold down a job and do things, to deal with finances and things like that. Relapse, 80% of your clients will relapse within 5 years. Increasing stress level and stopping their medicines are common contributors to relapse. Stress comes from the disease itself, from psychosocial changes related to the disease, like loss of employment, difficulties in personal relationships. All these things kind of build on each other. 2 strategies in dealing with your clients. You want to try to reduce those stressors as much as you can, help them with family counseling, help them, with jobs that they could maintain. The other sense is that you need to be teaching them coping skills to deal with their stress, because stress is going to increase their chance of relapsing into an acute psychosis. So We'll talk more about, like, you want to start identifying triggers for things that trigger them to more psychosis and trying to prevent that as much as you can. We talked a little bit about substance abuse already. Highly common with this condition, most substances, most commonly, are alcohol, marijuana, and cocaine. Obviously, that's associated with poor outcomes, partially because people who are abusing substances typically aren't going to also take their medicine because they're going to be more focused on getting the substance that makes them feel better immediately and not always the actual medication that would help them in the long run. Also, clients who are abusing substances are more likely to be hostile, violent, or suicidal because some of those substances are going to exacerbate their symptoms. So it feels to them like it's helping, but it may actually make their symptoms worse over time. Work, like we talked about, is going to be an issue. It's hard for them to hold down jobs due to cognitive declines. Also difficult for them to fit in socially at work. Psychosis-induced polydipsia is kind of a new concept. Haven't really touched on that. That is compulsive drinking of water. So these people may drink 4 to 10 liters of water a day, just constantly drinking water. Talk about, since you guys are right here. So what electrolyte problem might that cause for them? Anybody else over there have an answer? Mr. Fair, what fluid electrolyte problem might that cause?
Well, I had a student who offered you an answer.
I didn't hear it. What is it?
Low sodium.
Right. That's the most common one we worry about is hyponatremia with these people. So we keep an eye on their sodium. You may need to limit their fluid intake and be watchful of that. So, nursing process. What time is it? Let's take like a 10-minute break. How's that? Because it's 10:20. And we'll come back in 2 minutes.